Good morning. I am Dr. Koa, first year urology resident. For our topic today, I will be discussing the NCCN guidelines for kidney cancer. So some parts of this might be too technical for others, pero hindi naman, rest assured, you do not need to memorize this. You not, siguro familiarize lang, and especially for those who want to go into urology residency. So start off, so guidelines pala to So most of this would revolve around treatment and yung staging. So renal cell carcinoma comprises approximately 3.8% of all new cancers, with a median age of the diagnosis of 64 years. So approximately 85% of kidney tumors are RCC, and according to the guidelines, 70% have a clear cell histology. Other less common types include papillary, chromophobe, translocation, and Bellini duct tumors. Medullary renal carcinoma is a rare and aggressive RCC variant that almost exclusively arises in patients who are sickle cell trait positive. So for risk factors, we have smoking, obesity, and hypertension. So established risk factors for RCC development. So several hereditary types of RCC also exist, with von Hippel-Lindau disease or syndrome being the most common. It is caused by an autosomal dominant constitutional mutation in the VHL gene that predisposes to clear cell RCC and other proliferative vascular lesions. So the most important prognostic determinants of 5-year survival are the following: so tumor stage, tumor grade, local extent of tumor, presence of nodal metastasis, and evidence of metastatic disease at presentation. So usually the primary metastatic sites would be the lungs, bone, liver, lymph nodes, adrenal glands, and the brain. So patients with RCC would typically present with a suspicious mass involving the kidney that has been visualized using a radiographic study, often a CT scan. So as the use of imaging methods have become more widespread, the frequency of incidental detection of RCC has increased, and fewer patients present with the typical triad of symptoms, which is the hematuria, flank mass, and flank pain. So less frequently, the patients may present with signs and symptoms resulting from metastatic disease. So what are those? They would include bone pains, pag may bone mets, adenopathy, pulmonary symptoms, attributable to lung parenchyma or mediastinal masses. So as other presentations can include fever, weight loss, anemia, or a varicocele. So RCC in younger patients, which is less than or equal to 46, may indicate an inheritable disorder. So may kita sa guidelines na pag may RCC ka, tas less than 46 years old ka, or 46, they usually would suggest to undergo genetic studies. So a thorough physical exam should be performed along with obtaining a complete medical history of the patient. So laboratory evaluations could include a CBC, comprehensive metabolic panel, which may include calcium, serum creatinine, liver function studies, urinalysis. So CT scan of the abdomen with or without pelvic CT are essential studies in the initial workup. So other studies that are important would include a chest X-ray or CT scan on chest, or abdominal MRI to probably evaluate the inferior vena cava involvement, and bone scan or cranial MRI if symptomatic. So for the staging, ito na yung medyo madugo, no? Usually kabisado siya ng urologic oncologists and urologists. We use the AJCC, American Joint Committee on Cancer 8th edition. So TNM siya. Yung T0 would mean no evidence of primary tumor. Pag T1, 7 cm yung marker mo. So 7 cm or less, T1 ka. Pero may T1A and T1B. Ang T1A, less than or equal to 4 cm, and T1B is more than 4, but 7 or less din. So ang T1, 7 or less. Ang T1B, 7 to 4. T1A, 4 pababa. T2, greater than 7 but is limited to the kidney. Ang T2A, greater than 7 but equal or less than 10. Ang T2B, greater than 10, limited to the kidney again. Ang T3, tumor can extend into major veins or perinephric tissues, but not into the ipsilateral adrenal gland and not beyond the Gerota's fascia. So again, may 3A, 3B, and 3C. Ang 3A extends into the renal vein or its segmental branches, or invades the pelvic calyceal system, or invades the perirenal and renal sinus, but not beyond the Gerota's fascia. 3B, vena cava below the diaphragm. And 3C, mas kalat na, so above the diaphragm na. It invades the wall of the vena cava. And T4, tumor invades beyond Gerota's fascia and may extension ka into the ipsilateral adrenal gland. For the N, N0, no lymph node metastasis. N1, meron. So hanggang N1 lang kapag kidney cancer staging. N1. Yung M, as usual, M0 and M1. Yung M1, distant mets. M0, wala. As you can see sa AJCC prognostic groups, in stage 1 to 4, primarily, T-dependent. So on T1, stage 1, T2, stage 2, T1 to T2, na may N1 is stage 3, or T3, stage 3 din. Tapos yung stage 4, T4, tas any N, tas M0 or M1. So for the histologic grading, meron din siyang G1 to G4. Ang tatandaan nyo lang dyan is yung meron tayong 400 times magnification and 100 times magnification. So medyo complicated lang yan, pero ang 400 times magnification, isipin nyo lang, is yung high power field microscope. Ang 100 times is low power. So sa G1, naka-high power ka na, hindi mo pa makita yung nucleoli and basophilic. So G2, naka-high power ka, nakikita mo yung nucleoli, pero low power, nakikita mo siya, pero hindi prominent. Ang G3, nakikita mo na yung nucleoli at low power. And G4, marked nuclear pleomorphism and multinucleated giant cells. So mahirap siya yung tingnan, pero madali siya intindihin. Ito, kasama lang siya sa guidelines pero wala sa discussion. Usually, meron kang criteria para mag-search, mag-genetic studies for possible hereditary RCC syndromes. So, usually, pag 46 or less, meron kang RCC, test ka for genetic studies. Or, kapag meron kang bilateral or multifocal tumors, test ka pa rin. And, kung meron ka, RCC, kahit isa lang siya, kahit solitary, pero meron kang first or second degree relative with RCC, one or more than one, papatest ka din. And itong following histologic characteristics, yung multifocal papillary histology, hereditary leiomyomatosis, Birt-Hogg-Dubh syndrome, yung usually related sa chromophobe, yung oncocytoma. And yung angiomyolipoma, and yung succinate dehydrogenase deficiency. So, I think yung mga important lang naman sa table na to is meron siyang parang correlations. Pag von Hippel-Lindau, usually related sa clear cell histology, autosomal dominant. Pag tuberous sclerosis, siya lang yung related sa angiomyolipoma, and autosomal dominant din. Yung Birt-Hogg-Dubh, chromophobe, and hybrid oncocytoma.
Malabas yun. Tiyatulong yun.
So, ayun. Again, yung features lang, tuberous sclerosis and von Hippel-Lindau disease. Yung tuberous sclerosis, yun yung angiomyolipoma. Yung VHL, yung pheochromo, clear cell, and oncocytoma. So, for the treatment of localized disease, surgical resection remains an effective therapy for clinically localized RCC. So, radical nephrectomy usually, it involves the perifascial resection of the kidney, perirenal fat, regional lymph nodes, and ipsilateral adrenal gland. It is the preferred treatment if the tumors extend into the IVC and may be done through open laparoscopic or robotic surgery. Partial nephrectomy naman, initially, may original indication yan. Usually, pag RCC sa solitary kidney, pag meron kang bilateral, synchronous RCC, in other words, sabay nagkaroon, bilateral, or RCC in one kidney with inadequate contralateral renal function, pag may CKD ka na. Usually, partial nephrectomy or nephron-sparing surgery has been used increasingly in patients with T1A and T1B renal tumors and a normal contralateral kidney. Yun nga, hindi na siya, yung original indications niya, mas lumawak na ngayon. So, radical nephrectomy should not be employed when nephron-sparing surgery can be achieved. No, so the goals of nephron-sparing surgery should be optimal loco-regional tumor control while minimizing ischemia time to ideally less than 30 minutes. However, in some patients with localized RCC, nephron-sparing surgery may not be suitable due to locally advanced tumor growth or because unfavorable location. So lymph node dissection has not been consistently shown to provide therapeutic benefit. So aside from lymph nodes, assessment ng lymph node status is based on yung enlargement sa imaging and assessment by direct palpation at the time of surgery. So minsan, yung sa time ng surgery na nagde-decide. So the NCCN Kidney Cancer Panel recommends regional lymph node dissection for patients with palpable or enlarged lymph nodes detected on preoperative imaging tests. So for adrenalectomy, ipsilateral adrenal gland resection should be considered for patients with large upper pole tumors or abnormal appearing adrenal glands on CT. It's not indicated when imaging shows a normal adrenal gland or if the tumor is not high risk based on size and location. So active surveillance is defined as the initial monitoring of tumors using abdominal imaging techniques with delayed intervention when indicated. So it is usually used on elderly patients and mga high risk. And those with small renal masses and other comorbidities that have usually a low RCC specific mortality. So ablative techniques such as cryo or radiofrequency ablation are alternative strategies for selected patients. So for the management of stage 1 T1A disease, so ito yun sa taas. They recommend surgical excision by partial nephrectomy for management of clinical stage 1 T1A renal masses. It is the partial nephrectomy has been deemed the most appropriate in patients with small unilateral tumors or whenever preservation of renal function is a primary issue. But they also list radical nephrectomy as an alternative if not technically feasible. So although distant recurrence-free survival rates of ablative techniques and conventional surgery are comparable, ablative techniques have been associated with an increased risk of local recurrence. So the NCCN guidelines recommend active surveillance and ablative techniques only in selected patients, as previously discussed. For the management of stage 1 T1B disease, so may kita nyo dyan sa table, may nakalagay na preferred sa partial nephrectomy for T1A. Pero T1B nawala siya. Partial nephrectomy has an oncologic outcome noted to be similar to that of radical surgery for T1B tumors. Pero hindi na siya preferred. Surgery by partial nephrectomy whenever feasible or by radical nephrectomy is the standard of care for clinical T1B tumors according to the Kidney Cancer Panel. For stage 2 and stage 3 disease, radical nephrectomy is the preferred treatment for the tumors that extend into the inferior vena cava. So it often requires the assistance of cardiovascular surgeons because treatment-related mortality may reach 10%, depending on the local extent of the primary tumor and the level of vena caval extension. So partial nephrectomy is generally not suitable for stage 2 and 3, but may be considered for those still with small polar unilateral tumors. So for most patients with localized RCC, na clear cell, high risk, No established role in patients who have undergone a complete resection of their tumors, except patients with stage 3 disease, clear cell histology, and high risk for relapse. So usually, yung binibigyan nilang adjuvant therapy would be sunitinib for 1 year. So patients' treatment with sunitinib had a longer median disease-free survival compared to those with placebo. So for follow-up during active surveillance, the NCCN panel recommends a history and physical examination, a comprehensive metabolic panel, and other tests every 6 months for 2 years, and then annually for up to 5 years. In order to study the growth rate of the tumor, the NCCN panel recommends abdominal imaging within 6 months for 2 years from the initiation of active surveillance. Subsequent imaging annually din. Most follow-up tests after ablative therapy naman, included by the NCCN panel, are similar to the follow-up tests included during active surveillance. For imaging tests after ablative therapy, they recommend abdominal CT or MRI with and without IV contrast unless otherwise contraindicated at 3 and 6 months to assess treatment response, followed by annual abdominal CT or MRI scans for 5 years. The panel suggests repeat biopsy if there is radiographic evidence of progressive increase in size of unablated neoplasm with or without contrast enhancement, new nodularity in or around the treated zone, failure of the treated lesion to regress over time, or evidence of satellite lesions. For patients with stages T1A and T1B after partial or radical nephrectomy, the NCCN panel recommends history and PE, comprehensive metabolic panel, and other tests every 6 months for 2 years, and then annually up to 5 years. So the panel recommends a baseline abdominal CT scan for patients undergoing nephrectomy within 3 to 12 months following renal surgery. If the initial post-op imaging is negative, abdominal imaging beyond 12 months for patients who have undergone radical nephrectomy may be performed at the discretion of the physician. For patients with stage 2 to 3 disease after radical nephrectomy, larger tumors have a substantially higher risk of both local and metastatic recurrence. Therefore, yung follow-up niya mas rigorous. So they recommend history and PE every 6 months for 3 years, and then annually for 5 years after radical nephrectomy. So they recommend baseline chest imaging and abdominal CT scans within 3 to 6 months following surgery, with continued imaging every 6 months for at least 3 years, and then annually for up to 5 years. CT is the preferred modality for those with high risk of recurrence. So for relapsed or stage 4 disease, cytoreductive nephrectomy before systemic therapy would usually be recommended in patients with a potentially surgically resectable primary tumor mass. Studies suggested that cytoreductive nephrectomy continues to play a role in patients treated with VEGF agents. So patients with metastatic disease who present with hematuria or other symptoms related to the primary tumor should be offered palliative nephrectomy if they are surgical candidates. So patients with potentially surgically resectable primary RCC and oligometastatic sites are candidates for nephrectomy and management of metastasis by surgical metastasectomy or with ablative techniques for those who are not candidates for surgery. So they initially present with primary RCC and oligometastatic disease, or they eventually develop oligometastasis after a prolonged disease-free interval from nephrectomy or recurrence. So in patients whose tumors are surgically unresectable, the NCCN panel recommends performing tissue sampling to confirm diagnosis of RCC, to determine histology and guide subsequent management. Tumor histology and risk stratification of patients is important in therapy selection. The histologic diagnosis of RCC is established after surgical removal of renal tumors or after biopsy. According to WHO, the three most common histologic RCC types are clear cell RCC, papillary RCC, and chromophobe RCC. So may prognostic system sila to risk stratify patients in metastatic settings. So ito yung dalawa. So the most widely used prognostic factor model is from the Memorial Sloan Kettering Cancer Center or MSKCC, derived from examining prognostic factors in patients with metastatic RCC enrolled in clinical trials that are treated with interferon. So prognostic factors nila includes 5 variables. So interval from diagnosis to treatment of less than 1 year, Karnofsky performance status less than 80%, LDH greater than 1.5 times the upper limit of normal, corrected serum calcium greater than the upper limit of normal, and serum hemoglobin less than the lower limit of normal. So patients with none of these factors are low risk or with good prognosis. Pag 1 or 2 factors are present, intermediate risk, and pag 3 or more, poor risk. Yung sumunod na natin, prognostic model is the IMDC or Heng's model, derived from retrospective study ng patients with metastatic RCC treated with VEGF-targeted therapy, yung sunitinib. So the analysis identified 6 clinical parameters. The stratified into favorable, intermediate, and poor din. So 4 out of the 5 adverse prognostic factors as previously identified dun sa MSKCC are nandito din. Dito din siya. So yung 6 na yun is yung hemoglobin less than the lower limit of normal, serum corrected calcium greater than upper limit of normal, yung Karnofsky din na 80%, time from initial diagnosis to initiation of therapy of less than 1 year, and may dinagdag na absolute neutrophil count greater than the upper limit of normal and platelets greater than the upper limit of normal. So yung favorable risk groups, wala rin prognostic factors. Pag 1 or 2, intermediate. Pag 3 to 6, poor risk. So ito yung set ng systemic therapy that are advised para sa stage 4 or relapsed disease. So yung pazopanib, oral angiogenesis inhibitor targeting VEGF receptors, VEGF receptor 1, 2, and 3. And platelet-derived growth factor receptors. And yung stem cell factor receptor or c-KIT. So tatlo yung pazopanib. VEGF receptors, platelet-derived growth factor receptors, and stem cell receptors or yung c-KIT. While yung sunitinib, multi-kinase inhibitor targeting several receptor tyrosine kinases. So yung coverage ng sunitinib dun sa mga receptors, pareho din sa pazopanib. Pero may dagdag na colony-stimulating factor, tyrosine kinase, and neurotrophic factor receptors. Both have been listed by the NCCN Kidney Cancer Panel as Category 1, along with axitinib plus pembrolizumab. Preferred options for the first-line treatment of patients with relapsed or medically unresectable clear cell stage 4 RCC with good risk features. Yung sunod na drug na discuss nila sa guidelines is yung nivolumab. It is an antibody that selectively blocks the interaction between programmed cell death 1 or yung PD-1 and its ligands. So PD-1, PD-L1 inhibitor ang nivolumab. While yung ipilimumab, the antibody siya that selectively blocks the interaction between the negative CTLA4 receptor and its ligand. So pag sinama mo yung dalawa, yung NCCN Kidney Cancer Panel, they have listed nivolumab plus ipilimumab in combination as Category 1 preferred treatment option for first-line treatment for, ito naman, intermediate and poor risk patients. While yung pazopanib and sunitinib, sa good risk yun. So yun. Category 1 din siya na recommendation. And yung isa pa is yung cabozantinib. Ano siya? Small molecular inhibitor of tyrosine kinases. such as VEGF receptors, NMET, and yung NCCN panel, yung cabozantinib, category 2A recommendation siya for first-line treatment for poor and intermediate risk groups. So axitinib is a selective second-generation inhibitor of VEGF receptors 1, 2, and 3. And they have included axitinib as first-line treatment option category 2B for use under certain circumstances for patients of all risk groups. Pero pag sinama mo ng pembrolizumab, it becomes a first-line recommendation para sa favorable risk group na clear cell RCC na metastatic. So, yung next drug na dinescribe na sa guidelines is bevacizumab, recombinant humanized monoclonal antibody that binds and neutralizes circulating VEGF-A and in combination with interferon alpha. Category 1 option for the first-line treatment of patients of all risk groups with relapse or medically unresectable clear cell stage 4 RCC. And temsirolimus, inhibitor siya ng mTOR protein. mTOR protein regulates micronutrients, cell growth, apoptosis, and angiogenesis by its downstream effects on a variety of proteins. Yung NCCN Kidney Cancer Panel has included temsirolimus as a category 1 recommendation. Dun siya sa under certain circumstances for first-line treatment of poor risk patients. So yung iba ay subsequent therapy naman for clear cell histology. So para sa targeted agents, the role of targeted agents in non-clear cell RCC warrants investigation. So therefore, according to the NCCN panel, enrollment in clinical trials would be the preferred strategy for non-clear cell RCC na metastatic or nag-relapse. So data from expanded access trials, phase 2 trials, and retrospective analysis support clinical activity of sunitinib for non-clear cell RCC. And category 2A, preferred option for treatment siya for treatment-naive patients with stage 4 non-clear cell RCC. So cabozantinib, lenvatinib, and everolimus both all have category 2A listings as other recommended options. So for follow-up for relapse or stage 4 disease and surgically unresectable disease, the NCCN panel recommends a history and PE of patients every 6 to 16 weeks for patients receiving systemic therapy or more frequent PE if indicated. So other lab evaluations may be carried out as per the requirements for the therapeutic agent being used. So imaging, so CT or MRI, should be performed prior to initiating systemic treatment or observation. Subsequent imaging may be performed maybe every 6 to 16 weeks as per the physician's discretion. So lastly, supportive care. It remains a mainstay of therapy for all patients with metastatic RCC. So they still advise surgery for patients with oligometastatic disease in the brain whose disease is well controlled extracranially, usually stereotactic radiotherapy for limited volume brain mets, and whole brain irradiation kapag may multiple brain mets. So the NCCN Kidney Cancer Panel recommends zoledronic acid, or bisphosphonate, or denosumab, a rank ligand inhibitor, for selected patients with bony metastasis and creatinine clearance greater than or equal to 30 ml per minute. So denosumab was reported to be non-inferior to zoledronic acid in delaying time to first on-study skeletal-related events. And daily supplemental calcium and vitamin D are strongly recommended for my bone mets. That ends my lecture.
Nice. Okay, so hi guys. Hindi na ako magtatanong kay Dr. Kowa kasi magkatapat lang kami. But I would just like to summarize or let you know as a primary physician on what you can do. Because how can this presentation be relevant? Okay, so first of all, usually you'd see patients with an incidental finding of a renal mass via ultrasound. So, i-refer sa inyo yun. So, I just want you to know the dictum should be, it's RCC So most common kasi, di ba? Papillary RCC, clear cell type. Cancer, RCC, unless proven otherwise. So, do you refer to your urologist right away? So, kunwari, nag-moonlight kayo or nag-clinic kayo. So, most of the time, hindi.
Ang gagawin nyo, pwede nyo
gawin based on dun sa screening report kanina ni Dr. Kung, you do a contrast study or on our terms, a CT urogram. So, a CT urogram, next time interactive na tayo ha. So, I'll ask you guys. A urogram is CT scan with contrast. So, maraming cases yun. So, may delayed, may nephrogenic, may cortical. So, malalaman mo yung cases nung scan. So, basically, you get that. And then, once you see an enhancing or solid renal mass, that would confirm your diagnosis of your consideration of RCC. Pero syempre, RCC is a histologic finding. But yun nga yung dictum natin. Cancer unless proven otherwise. So what's the main treatment for RCC or a renal mass? So the treatment is always surgery. Based on kahit stage 1 to 4 pa yan, T1 to 4. So everything will all boils down to surgery. So the next question is, tatanong sa inyo ng patient, yun nga, surgery or is there a role for biopsy? Gusto ko sagutin yan dahil. Role for biopsy.
Usually, you would, kapag may relapse, sa kabilang side, sometimes the urologist can ask for biopsy. Pero pag same side, usually, mayroon tayong algorithm for stage 4 or relapse na hindi na imaging yung require. Kaya kapag nagsususpect ka ng cell histology, pwede ka rin for biopsy.
Okay, tama naman yung sinabi ni Daryl, but I would just like to add yung role ng biopsy. So, hindi lang for stage 4. So, usually you have high suspicion for infection, inflammation, lymphoma. You can do your biopsy. So, yun yung tatanong sa inyo ng patient. Kasi sabihin yan, cancer po ba talaga? So, yun, tatanong sa inyo yung role ng biopsy. But basically, bukol man yung tatanggalin. How about renal cyst, Daryl? Can you talk about renal cyst? Hello?
Kung sa renal cyst naman, usually, meron tayong sinatawag na box niya classification to identify yung mga renal cysts. So, meron tayong category 1, 2, 2F, 3, tsaka 4. Yung treatment mo would vary depending on yung classification niya. Pero generally, usually naman pag sa clinic, makikita nyo, mga thin wall, may constipation, box na 1 or 2 yun. Usually, you observe lang. And then you repeat imaging after time intervals.
So, that's it for our Daryl's lecture. Nandiyan pa si Vince? Backlog kasi kami from the last group. So, represent sila. May click lang naman. Vince?
Bro. Yes, sir. May question lang ako kay Daryl. Sorry. Hello?
Hello?
Daryl.
Yes.
For example, you have a patient. And then yung patient, you did a biopsy of the patient dahil T4 yung mass niya. So, and then, when the biopsy results came out, it turned out na equivocal yung result. Meaning, hindi nila mabasa kung clear cell or non-clear cell siya. How would you go about with the patient?
Sir, mag-refer na ako sa urology.
Pwede, actually. That's a good, Siyempre, if you don't know what to do, you should refer. Pero, ang dictum kasi dyan, since ang most common pa rin na cancer mo is a clear cell, treat it as a clear cell. So pag ganun kasi, ang iisipin mo, you give a neoadjuvant chemotherapy targeted to a clear cell, kahit equivocal yung result. And then if it turns out na nagdi-decrease yung cancer, you take care of the lymph node mets, then you might do a cytoreductive nephrectomy. So yun, actually yung mga tinatanong sa service, concerning sa mga when to do biopsy. So if you have a bilateral renal mass, have to do a biopsy, metastasis, abscess, or a lymphoma, kidney, consideration of a melanoma versus an RCC, magbabiopsy ka. Pero, great report. Okay report ko.
Thank you, sir.
So that's Dr. Sergio, one of our alumni. Vince?
Yes, sir. Sige.
Tapos na sila? Pwede naman yun. Ano? Baka pwede na. Si Vince, mag-record, mag-moderate ka. Pag ano, hindi lang T4 na mag-biopsy kita. Pag high suspicion ko ng mga, kunwari, TB, o kaya abscess,
Infection.
lymphoma.
Magbabiopsy ka sa abscess.
Hindi, in high suspicion, kunwari, nakita mo, mukhang renal mass, pero symptomatic, may TB, may HIV,
Percutaneous biopsy.
o kasi inflammation, pwede ka rin mag-biopsy. Kasi baka may tanggalin. Kunwari, solitary kidney.
I am PGI Canlas, and together with my co-PGIs, we will be discussing about the physiology and pharmacology of bladder and the urethra. Next slide. So the reference for this topic is based from Urology 12th edition by Campbell. Next. So the bladder can be divided into several parts. A body lying above the urethral orifices and a base consisting of the trigone and the bladder neck. The bladder base has a laminar architecture with a superficial longitudinal layer lying beneath the trigone, and a muscle layer deep to the superficial layer is continuous with the detrusor. In men, the closure of the bladder neck facilitates the antegrade ejaculation, which is accompanied by a rich noradrenergic innervation by sympathetic nerves that actively contract the bladder neck during ejaculation. And in women, the density of the adrenergic innervation in the bladder neck is reportedly less than that in men. Next. So for the bladder compartments, we have the urothelium, lamina propria and vasculature, stroma, which comprises of the collagen and elastin, and the smooth muscle. Next slide. So for the urothelium, it is a multi-layered epithelium with a basal, intermediate, and apical layer of cells, which make up the layer that is in contact with the urine and microorganisms. They are also unique in their expression of an assembly of a specialized class of proteins called the uroplaquins. Next. So the uroplaquins are assembled within the apical membrane of the apical urothelial cells within specialized areas called the plaques. The plaques have a membrane outer leaflet that is thicker than the inner leaflet, resulting in asymmetry. That is, it is also called as the asymmetrical unit membrane. The areas between the plaques are symmetrical in terms of the outer and inner leaflet thickness, and this area is called the hinge region. Next, please. The lamina propria is the functional center for localized control of the bladder, coordinating the activities of the urothelium and the detrusor smooth muscle. Within are a diffuse plexus of unmyelinated nerve fibers making contact with the urothelium, blood vessels, and the detrusor smooth muscle. Aside from the nerve fibers, there are also interstitial cells or myofibroblasts and the microvasculature, which are primed to modulate the physiologic interactions between the urothelium and the detrusor smooth muscle. The large horizontal plexus of the blood vessels located in the lamina propria is termed as the mucous plexus, and the another plexus just under the basal urothelial layer is termed as the subepithelial plexus. During normal filling, the blood flow is able to adapt to the large increase in surface area until the pressure in the bladder increases. And the principal determinant of blood flow in the bladder wall is the intramural tension. Next. The passive mechanical properties of the bladder wall depend on the viscoelastic properties of the stroma and of the relaxed detrusor smooth muscle. The stroma has commonly been considered as a passive low metabolic tissue that fills out the space among the muscle bundles, vessels, and the nerves. And during bladder hypertrophy, it is likely to involve an interaction of the stroma and smooth muscle. The main constituents of the bladder wall stroma are the collagen and elastin in a matrix composed of proteoglycans, and the most common types of collagen are types 1, 3, and 4. Next. In this figure, it shows that the motor innervation of the bladder smooth muscle is from the postganglionic parasympathetic nerve fibers, and it also shows the varicosities that wrap around the smooth muscle fiber, which can release a variety of neurotransmitters, including the acetylcholine and adenosine triphosphate. The presence of gap junctions allows the excitation to propagate throughout the smooth muscle syncytium. So the post-junctional receptors, such as the muscarinic and purinergic receptors, are present on the smooth muscle cell, and when they are activated by their respective agonists, these receptors initiate the excitation contraction events of the smooth muscle. Next. So here is an example of the male urethra, wherein the red area is the external and the purple area is the prostate. Next. This is the female urethra, where it extends the distal third of the anterior from the bladder neck to the meatus. It is composed of tissues that aid continence in addition to the urethral sphincter, and also a network of vascular subepithelial tissue in women contributes to a urethral seal effect and promotes continence. The external urethral sphincter or rhabdosphincter is under control and is part of the pelvic floor musculature. Next, please. For the fiber types of urethral striated muscles, the contraction of striated muscle is governed by intracellular calcium through interactions with troponin. And it is classified as the slow type and twitch type, and the twitch type is further classified as the slow twitch and fast twitch. The slow twitch fibers are suited to maintain the sphincter tone for prolonged periods and is found in greater percentage in muscles such as the pelvic levators and urethral sphincter. It possesses less of the myosin ATPase activity and contains an increased expression of a slow isoform of the calcium ATPase. Next. While the fast twitch fibers may be needed to add to the sphincter tone rapidly to maintain the continence when intra-abdominal pressure is abruptly increased. It exhibits rapid bursts of contractile force and are rich in myosin ATPase that catalyzes the actin-myosin interaction. The rhabdosphincter is a skeletal muscle that is present in the walls of the urethra. It is separate from the periurethral skeletal muscle of the pelvic floor. It is composed of two parts. First is the periurethral striated muscle of the pelvic floor, which contains the fast twitch and slow twitch fibers, which are adapted for the rapid recruitment of motor units required during increases in abdominal pressure. And the second part is the striated muscle of the distal sphincter mechanism, which is predominantly slow twitch fibers and provides more than 50% of the static resistance. Next. So for the urothelial physiology, the primary role of the urothelium is to form a relatively impermeable barrier to protect the underlying stroma of the bladder. The epithelial permeability depends on a number of factors. These are passive diffusion, osmotically driven diffusion, active transport, and the inertness of the membrane to the solutes to which it is exposed. The urothelium maintains an osmotic gradient between the plasma and the urine, depending on the level of the water balance and diuresis of the individual. The tight junction proteins also contribute to the impermeability of the bladder urothelium, and it includes clodins 4, 8, and 12, wherein they adapt to the stretch of the urothelium during filling and voiding without affecting the permeability. Next. So for the urethral tone, the blocking striated sphincter activity with nicotinic neuromuscular blocking agents has variable effects and may reduce the urethral tone, but rarely by more than 40%. Blocking the sympathetic tone with alpha adrenoceptor blockers may also reduce urethral pressure. Urethral pressure recording at the external sphincter during bladder filling increases uniformly along the entire circumference, and it is augmented by norepinephrine or hypogastric nerve stimulation, suggesting a role for adrenergic receptors and sympathetic nerves in the function of the external urethral sphincter. The vascular filling of the urethral lamina is known to be of importance for urinary continence, and estrogen is known to increase the urethral blood flow, resulting in increased distension of the lamina propria blood vessels. If the arterial blood supply to the urethra is impaired, intraluminal pressure decreases. Next. For the ionic transport, sodium channels that exist on the apical surface of the umbrella cells and in the cytoplasmic vesicles below the apical surface are primarily amiloride sensitive and aldosterone responsive. However, amiloride insensitive, cation selective, as well as amiloride insensitive, unstable cation channels have also been identified. Both of these channels were found to be degradation products of the amiloride sensitive sodium channel, which is hydrolyzed by serine proteases such as kallikrein and urokinase, as well as the plasmin. Next. Here are examples of sensor molecules associated with the neurons that have been identified in the urothelium. So when the urothelial cells are activated through these receptors and ion channels in response to mechanical as well as chemical stimuli, they can in turn release the chemical mediators such as nitric oxide, ATP, acetylcholine, and substance P. Chemicals released from the urothelial cells may act directly on the afferent nerves or indirectly through an action on suburothelial interstitial cells that lie in close proximity to afferent nerves. Next. Prostaglandins are also released from the urothelium, and these are the assigned two possible functions. One is by regulation of the detrusor muscle activity, and number two is the cytoprotection of the urothelium. The predominant forms of prostaglandins are 6-oxoprostaglandin F2 alpha, followed by prostaglandin Fe2, followed by prostaglandin F2 alpha, and thromboxane B2. Prostacyclin is also being produced. The urothelium-derived inhibitory factors decrease the force of the detrusor muscle contraction in response to muscarinic stimulation. Next. So here are the key points of the urothelium. Next, please. So this table only shows the comparison of the properties between the smooth and skeletal muscle. Next. So the bladder smooth muscle cells contract by the interaction of the thick and thin filaments within the intracellular cytoskeletal network. They are bound to thick filaments are composed of myosin, while the thin filaments are composed mainly of actin. They are bound to actin, the tropomyosin, and caldesmon, both of which are important in the regulation of the contraction. Intermediate filaments are composed of desmin and vimentin. Next. Thick and thin filaments of the smooth muscle fibers are arranged as myofibrils that cross the fibers obliquely in a lattice-like arrangement that attach to multiple sites within the cytoplasm at locations called the dense bodies. Filaments of the contractile proteins are also attached to the plasma membrane at junctional complexes between the neighboring cells, which allow the smooth muscle cells to contract as a syncytium. The thick filaments are made up of myosin II, two intertwined myosin heavy chains. There are two areas of the myosin II, the rod portion, which contains the coil region, and the head region, which contains the globular domains of the two myosin heavy chains, with an intervening junction between the coil and the head. Contained within each globular region of the myosin heavy chains are two myosin light chains, which are myosin light chains 20 and 17. Next. So this image only shows a single myocyte going from relaxation to contraction, and the importance of actin polymerization at the periphery of the cell is that this network strengthens the membrane for forced transmission from the actinomyosin cross bridges. The regulation of actin polymerization is distinct and separate from actinomyosin cross bridge cycling. The interaction between actin and myosin in smooth muscle contractions is modulated by the actin-binding proteins caldasmon and tropomyosin. These two proteins control access points on the actin filament to allow myosin II heads to form cross bridges. Next. The caldasmon is an inhibitor of actinomyosin ATPase and motility, and actin binding and caldasmon inhibition are greatly enhanced in the presence of tropomyosin. The two isoforms of caldasmon are heavy caldasmon, which is associated with all smooth muscle, and the light caldasmon, which is associated with non-smooth muscle cells. The caldasmon is modulated by another protein, which is calmodulin, that interacts with intracellular calcium to initiate the contraction. So in this box, we can see the detrusor smooth muscle contraction sequence, wherein the key step in smooth muscle cellular contraction is cross-bridge formation of myosin II heads to actin, which is dependent on the rise of the intracellular calcium. Next. So the determination of the smooth muscle tone is therefore dependent on the balance of intracellular calcium and the balance between myosin light chain kinase and myosin light chain phosphatase activities. The myosin light chain phosphatase activity is under the control of a series of complex molecular events related to two proteins, which are Rho-A and Rho kinase or Rho-K. The activity of Rho-A is based on the form of guanine phosphate bound to Rho-A, and the inactive Rho-A is bound to guanosine diphosphate, while the active Rho-A is bound to guanosine triphosphate. There are three classes of regulatory proteins that control the cycling between the active Rho-A and inactive Rho-A forms. These are the guanosine nucleotide exchange factors, GTPase activating proteins, and the guanine nucleotide dissociation inhibitors. Next. So the smooth muscle cells are excitable and contractility is dependent on the membrane potential. And here is the approximate concentrations of these ions. Next. And the equation for calculating the membrane potential is determined by the Goldman-Hodgkin-Katz voltage equation. Next. So this image shows the membrane potential and the current flow in a detrusor myocyte action potential. There are four phases of the action potential, and each phase is mediated by a different ionic current. Phase 0 is slow depolarization. Phase 1 is the fast upstroke of the action potential mediated by calcium inward current. Phases 2 and 3 are hyperpolarization of the action potential mediated by potassium outward current. Next. So when acetylcholine activates the smooth muscle muscarinic M3 receptors, smooth muscle intracellular calcium concentration increases through two mechanisms. One is by extracellular entry through volume-dependent calcium L-type channels, and by release of intracellular calcium stores via G protein activation with resultant inositol triphosphate production. Next. Once the M3 receptor is activated by acetylcholine, it activates the alpha subunit of the GQ protein. The activated G protein then activates the membrane-bound enzyme phospholipase C, and the activated phospholipase C cleaves a membrane phospholipid, which is the phosphatidyl inositol 4,5-bisphosphate, to form the cytosolic inositol triphosphate, which binds to its receptor at the sarcoplasmic reticulum, which causes the stored calcium to be released. The other product of phosphatidyl inositol 4,5-bisphosphate cleavage is remains membrane-bound and binds to protein kinase C, which is bound to the membrane, thereby activating it. Protein kinase C goes on to phosphorylate the myriad proteins to induce the secondary signals. Next. The normal contraction in the human detrusor smooth muscle is mediated by acetylcholine, and in disease states, the excitation neurotransmitter could possibly be caused by ATP. There are some studies wherein human bladders from obstructed and overactive bladder subjects have been found to have atropine-resistant contractions that were blocked by the ATP receptor blocker alpha-beta methylene ATP, suggesting a purinergic excitatory component to the pathologic bladder contractions. Next. Intracellular calcium in the detrusor myocyte can also be regulated by various mechanisms. One is by exchanging for sodium ion. Next is by pumping out of cell using adenosine triphosphate. Third is by pumping into sarcoplasmic reticulum with circa ATP or sarcoplasmic endoplasmic reticulum calcium ATPase. Fourth is by binding to calcium binding molecule. And lastly, by pumping into mitochondria. Next. So this image only shows the molecular structure and function of the gap junctions, wherein the specialized proteins called the connexin are expressed between the membranes of connected smooth muscle cells. The basic unit of connexin 43 is composed of 4 transmembrane domains with the carboxy terminal and amino terminal intracellularly. Next. Lastly, for the detrusor interstitial cells, in addition to being located in the suburethral layer, they are also found in the detrusor layer and have been shown to be spontaneously active. They can fire calcium waves in response to cholinergic stimulation by M3 receptor activation and can be spontaneously active, suggesting that they could act as pacemakers or intermediaries in transmission of nerve signals to smooth muscle cells. Interstitial cells in the detrusor may be more important for modulating the transmission of the calcium transients originating from the smooth muscle cells. Next. So here are just some of the key points for the smooth muscle mechanics.
Good morning, everyone. My name is PGI Cruz, and I'll be reporting to you guys about the bladder mechanics. Next, please. So, as you can see here in the picture, obtained from Google, before going to the complicated mechanism, I can discuss to you guys first the basics first. So, as you can see, there are 3 phases. First is the filling and storage phase. Next is the voiding phase. And third is the termination of voiding. So during the first phase, you have the detrusor muscle being relaxed, and then the sphincter, external sphincter, being contracted, so that the volume so that the urine or the volumes inside stored inside. And then you have the phase 2, which is the voiding phase, where the detrusor contracts, and then the urine is expelled out, while the external sphincter is now relaxed rather than contracted. And then the phase 3, it goes back, like a cycle, goes back where the external sphincter contracts, and then the detrusor is still relaxing right now. Next, please. So here you have the urinary stage filling. The behavior of the bladder depends on the neuromuscular and mechanical properties. So the bladder is composed of smooth muscles, mostly, and then 50% collagen and an elastin, which is I think 2%. And then when the bladder is injured, obstructed, or any denervation happens, the collagen increases, which is bad, because if you have higher collagen, it can cause lower distensibility and lower compliance. The thickness of the lamina propria and the trusser are important for the bladder accommodations. So in feeling, the lamina propria thins out due to the rearrangement of muscle bundles and alteration of collagen coil structure. So, and also during the feeling, you have the trusser reorganizes and muscle bundles shift positions from top to bottom to a side-to-side configuration. Next, please. So in here, basically, the compliance is equal to the change in volume over the change in intravascular pressure. So if you have higher pressure, meaning it can decrease the compliance. Yun. And then feeling the bladder at a slow physiologic rate maintains an intravascular pressure of less than 10 supposedly. So pressure, the volume curve during feeling is dependent on the following factors. So it can change through the collagen, elastin, the amount of smooth muscles, the active properties of smooth muscles, and the geometry of bladder. When there is a decrease in compliance of bladder, you have the fast feeling rate. It can be due to the fast feeling rate, composition of the bladder wall changes, hyperactivity of the smooth muscles, or either the combinations of all. Next. So as you can see in this picture, it just basically tells you the relationship between the pressure, the trusser pressure, and the bladder volume, where it can change of expulsion due to the increase in pressure. Next, please. So in theory, say it in Campbell, afferent signals from bladder wall during feeling are relayed to the CNS, which in turn inhibits the spontaneous smooth muscle contractions, which helps the bladder be more compliant. So it relays signals to the CNS where it says stop contracting so that the bladder won't expulse the urine out, avoiding. Next, please. So here you can see here is the motor sensory network, where shows a very complicated picture, but I'll just explain to you guys a brief summary. So on the right side, you have two gray circles. Those are the intradetrusor ganglia, which supplies usually the postganglionic efferents to the detrusor muscle. So as you can see, the green and the red lines, those are the afferent signals, which gets the afferent signal and then transports it to the main area, where as you can see, the lower left part, the external ganglia, that's the external ganglia where it receives the efferent naman and sends it to the motor nerves, which is the detrusor muscle. Next, please. So in the neural control of the LUT, or the lower urinary tract, it is innervated by the parasympathetic, the sympathetic, and the somatic nervous system. So the parasympathetic, it's innervated by the pelvic nerve, arises at the sacral level of the spinal cord, and it excites the bladder and relaxes the urethra. While the sympathetic part, which is the lumbar nerve, or from what I read, it's the hypogastric nerve, inhibits bladder body and excites the bladder base and urethra. And then the somatic part, the pudendal nerve, excites the EUS. Next, please. As you can see here, it's obtained from Google again. You can see a simple picture where it shows the innervations, where the pelvic nerve, or as I said a while ago, the parasympathetic part of the innervation comes from the sacral part, and then the hypogastric or the sympathetic comes from the lumbar part, and the pudendal and somatic. Next, please. So the parasympathetic pathway, the preganglionic neurons are located in the lateral part of the sacral intermediate gray matter in the sacral parasympathetic nucleus. They send axons through the ventral roots to peripheral ganglia, where they release the excitatory transmitter acetylcholine, while the parasympathetic postganglionic neurons are located in the detrusor wall layer as well as the pelvic plexus. Next, please. While the sympathetic pathways, the activation of sympathetic nerves induces relaxation of bladder body and contraction of a bladder outlet and urethra. The peripheral sympathetic pathway follow a complex route that passes through a series of sympathetic chains. As I'll explain it later. Next, please. So in the somatic pathway naman, the US motor neurons are located along the lateral border of the ventral horn, referred to as the omuth nucleus, and the sphincter motor neurons are also exhibit transversely oriented dendritic bundles that project laterally into the lateral fumiculatus, dorsally into the intermediate gray matter, and dorsomedially toward the central canal. Next, please. So as you can see here in this picture, it just basically shows where the sympathetic preganglionic pathways comes from the lumbar spinal cord, as you can see in the right side, and then it passes through the SCG and the ISN, or the sympathetic chain ganglia, or and the inferior splanchnic nerves, and then they go to the IMG, or the inferior mesenteric ganglia, where they go to the hypogastric nerve, which is now usually the sympathetic give a nerve. And then you have now the under it naman, for the parasympathetic naman, it passes through the sacrospinal it passes through the dorsal root ganglia, and it goes to the pudendal and both pelvic nerves. Next. So here the afferent pathway, the neural mechanism are organized by local spinal and brain circuits. Majority of the time is spent on storage mode, then switches to micturition. The switch relies on the sensory signals, which provide input to reflex circuits that control bladder filling and emptying. So the afferent fibers are inhibited by the pelvic, hypogastric, and the pudendal nerves. Axonally taken up by the afferent nerves, are transported to afferent cell bodies and terminates in the dorsal horn of the spinal cord. So for the pelvic and pudendal, you have in the sacral dorsal root ganglion, while the hypogastric nerves are from to the rostral lumbar dorsal root ganglion. Next, please. So the central axons of the DRG neurons carry the sensory information from the LUT to second order neurons in the spinal cord. The second order provide basis for spinal reflexes and ascending pathways to higher brain, rhythmic continence, and mediation of sensation. Pelvic nerve afferents, which monitor the volume of the bladder and the amplitude of bladder contractions, consists of myelinated and unmyelinated C axons. Here is just a picture showing the pathways. It's a cross-section of the spinal cord. On the left side, you can see the afferent pathways, and the right side on the efferent. But it's bilateral. But for this picture lang, it just shows you where are the pathways located on the spinal cord. Next, please. In this picture on the left side, it just shows you the normal micturition reflex on top, upper left pala. It shows you it's inhibited by the myelinated alpha delta afferent pathway, and then below it just shows you what happens to it when it shifts to the alpha delta fiber to the C fiber predominant when you have neurologic diseases, inflammatory diseases, or any aging. And then during the neuropathic conditions and possibly inflammation, as I said a while ago, there is a recruitment of C fibers instead of the myelinated alpha fibers that can cause urgency, incontinence, and bladder pain. Next, please. So the afferent discharges that occur during a bladder contraction have an important reflex function and appear to reinforce the central drive that maintains the detrusor contraction. Functional properties of the bladder afferents as follows. Only unmyelinated nerves in the urothelium and immediate suburothelial layer with small myelinated nerves being closely associated with smooth muscle layers, and another is plexus of afferent nerves in the lamina propria is the thickest in the bladder neck and its initial portion of the urethra, and becomes less dense in adjacent regions such as the cranial region. Next, please. So in here, in this picture, it just shows you that the ATP can be released from the urothelium, and then it may send, because this picture shows the actions of chemical mediators that may sensitize the mechanico-sensory nerve endings. So in this case, as I said a while ago again, the ATP is released from the urothelium, which can be sensitize the P2X receptor, the PTX subtype receptor, unergic receptors. The ATP can be released by the urothelium by stretch of the mucosa during bladder distension. So other parts naman via axoplasmic transport, which is stimulated by distension and chemical stimulation, can secrete neuropeptides such as the neurokinin A, which can act on the NK2 autoreceptors and can also sensitize the mechanical sensitive endings. This mechanism can also be induced by high urinary potassium concentrations and other sensitizing solutions within the bladder lumen, such as high osmolality or low pH, and they can also generate, and they can also cause mechanical sensitivity endings to activate also. Next, please. So the relationship between stimulus and response can be altered or modified according to mechanical and chemical environment of sensory endings. Many mediators are released during inflammation, injury, and ischemia, as well as from a number of cell types such as mast cells, fibroblasts, and neurons. Some mediators act directly on while others act indirectly, causing release of other agents from nearby cells. So examples of local mediators are neutrophils, purines, proteases, prostanoids, and cytokines. Next, please. So here, it's how they act. The local mediators are as follows. So it acts directly by opening ion channels on nerve terminals. Another one is it sensitizes endings without causing direct stimulation, but causes hyperexcitability to other chemicals and mechanical stimuli. And in specific cases such as the neurotrophins, they can change the phenotype of afferent nerves over long periods. Next, please. So the nitric oxide, it's a major inhibitory transmitter that mediates relaxation of urethral smooth muscles during micturition. It's mainly involved in controlling blood afferent nerve activity. So the purinergic signaling naman, the urothelium releases ATP in response to stretch. As I said a while ago in the picture, it responds to the P2X2 or the P2X3 receptors on unmyelinated afferent fibers, and then it is released by stretch and it activates the P2X2 and P2X3 receptors. There should be a balance between the excitatory effects of ATP and the inhibitory effects of the NO, and this will help determine the micturition thresholds and urinary frequency. Next, please. So you have three main neural pathways that regulate the LUT: the sacral parasympathetic, the thoracolumbar, and then the sacral somatic or the pudendal nerves. The parasympathetic postganglionic fibers terminate predominantly at the detrusor muscle, and they release acetylcholine, resulting to the detrusor contraction during voiding. So other that can affect the pathways are the parathyroid hormones related protein. They are released from the detrusor smooth muscles upon stretch and may act as endogenous DSM relaxant, the detrusor smooth muscle relaxant during bladder filling. Another molecule that can react to the pathway is the glutamate, which is present in the terminals of primary afferent neurons in the spinal cord, along with interneurons and fibers originating in the medulla oblongata. It acts on spinal neurons through a variety of receptor subtypes like the NMDA receptors, which control polysynaptic reflex pathway at the lumbosacral levels. Next, please. So as you can see in this picture naman, it just basically shows the mechanism of storage reflexes and also the voiding reflexes on the right. Next, please. So in the efferent pathway, there are a lot of factors that can have a major role in the pathway. So you have the glycine and the gamma aminobutyric acid. They have a major role in neural controls, mediating bladder function. Their projection to the lumbosacral cord inhibit the micturition reflex and inhibit glutamatergic neurons. Another one is serotonin. Its spinal reflex involved in voiding functions have a dense innervation. Activation can suppress voiding by inhibiting the parasympathetic excitatory input to the urinary bladder. Another one is the adrenergic transmitters. Descending catecholaminergic neurons are primarily located in the upper medulla or pons. Reflex bladder activity is modulated by at least 2 alpha and one adrenergic mechanisms. Next, please. So in the different pathway again, the reflex circuitry controlling continence and micturition, multiple reflex pathways organized in the brain and spinal cord mediate coordination between the urinary bladder and urethra. The central pathways are organized as an on and off switching circuits that maintain a reciprocal relationship between urinary bladder and urethral outlet. In the picture on the right side, it just shows the anatomy of the lower urinary tract and its switch-like processes during the micturition reflex pathway. Next, please. So during yes, Podo.
Hello?
Yes, Doc.
Okay na. Ano na eh. Lunch time.
Alam mo, bawal nagugutom.
Bawal tayo magutom. Pero maganda na yung report niya. Parang detailed, no?
Sorry, Doc. Medyo mahaba yung chapter.
Sa pang ano eh, pang 30 minutes. Eh, mga 47 yung